Okay, hello everyone. My name is Rob Cooper. I'm a cardiologist with an interest in cardiomyopathy at Liverpool Heart and Chest Hospital. I'm involved with the care of cardiomyopathy patients there for the last 5 to 6 years. I know some of you have tried to make yourself available for other conferences in the past. This year I've been tasked with talking to you about medication and treatment. And firstly, an apology that I can't be there in person. I had promised my children that we'd go away for the weekend that this is on, so I am very sorry. But I appreciate the efforts of Cardiomyopathy UK in facilitating recording this and showing it to you on the day. We'll start with some habits and lifestyle and hypertrophic cardiomyopathy. And this is preceding the medications and treatment because it is as important as some of the other medical interventions that we make. How you live your life can make a major impact on outcomes and the quality of life for the long term. First, there's an acknowledgement that fit people live longer. This may seem like a complex graph to start off with, but generally, over on this corner of the graph, everybody starts alive. And by the end of this graph, at 45 years, everybody has passed away because they start observing people in midlife. The blue line is fitter people, the red line is unfit people. So at about 25 years' time, you've got about twice the chance of passing away if you are unfit versus being fit. And this is the general population. So this is true across all disease states and even across health. I think it's fair to say that a lot of people with cardiomyopathy, specifically hypertrophic cardiomyopathy, have adopted a largely sedentary lifestyle, either because of advice they've been given in the past or through fear of what exercise might do to their heart. And this can have knock-on effects. It can lead to health complications. It leads to inactivity and some cardiorespiratory ill health. It can also lead to obesity. It can lead to the onset of diabetes and even to high blood pressure. And exercise is a good treatment for all of these things. And we should be considering allowing our patients with hypertrophic cardiomyopathy to do a bit more exercise. Obesity is a real problem, not only in patients with cardiomyopathy, but across the population. But it's fair to say that obesity contributes towards poor health outcomes in the general population. And in addition to that, a more rapid deterioration of illness in patients with cardiomyopathy. So we should be doing everything we can to try to avoid this. And this feeds into a whole healthier lifestyle, which includes changing your eating habits. So trying to adopt sustainable eating habits rather than a fad diet, incorporating some exercise and healthy living. These strategies aimed at preventing obesity do play a very important part in offsetting not only the ill health that cardiomyopathy can bring, but also other things. If patients with cardiomyopathy survive to a long age, and most do, then they are at risk of diabetes, coronary artery disease, heart attacks, stroke, all of the other things that patients who do not have cardiomyopathy are at risk of. And exercise and a healthy eating habit changes this quite significantly. There has been some very good work on behalf of the Cardiomyopathy UK organisation looking at how much of an impact having a diagnosis of cardiomyopathy makes on how you feel, on your mental health. And it's clear that people with cardiomyopathy have some effect on their mental health and emotional well-being a lot of the time. It affects 20% all or most of the time, 30% some or most of the time, and even up to 10-15% occasionally. It also affects people around them, with family, friends and carers admitting to a similar level of occupying thoughts and effect on mental health. If we then couple in the fact that people who exercise have better mental health, and those who exercise have about 1.5 fewer days of poor mental health per month, and reduces the burden by up to around about a fifth. Interestingly, team sports rank highest in this because you have that sense of camaraderie and belonging as well as the endorphins that exercise gives you, but gym activities are also high. Generally, the target in the end of a graded program would be to get up to 45 minutes for somewhere between 3 and 5 times a week. Now, for patients with hypertrophic cardiomyopathy, there's a long-standing fear that it causes adverse outcomes. It could accelerate the disease progress or cause risk when you're exercising. And I don't think that a lot of that is really borne out in the evidence that we have recently. Recent sets of guidelines have tried to dispel this and encourage some physical activity. And conversations with the cardiomyopathy team are always valid and appropriate to consider what sort of activity is appropriate for you. But in these guidelines, there were no data to support an acceleration of the disease process, so making the cardiomyopathy worse by those who exercise. Now, that's different to other disease processes such as arrhythmogenic cardiomyopathy. This is about hypertrophic cardiomyopathy. And guidelines across the United States on the top and across Europe have suggested that actually, if our patients have a fully informed decision and understand that the risks are low, with appropriate risk stratification, which often includes some tests, then we should be encouraging these people to do some exercise. If we then look briefly at the outcomes in some athletes who were diagnosed with hypertrophic cardiomyopathy as a result of screening processes, perhaps, some would stop playing and some would continue because sport is important to them. And in these two groups of observational research, there was no significant difference in terms of the outcomes between athletes who continue playing and those who stopped. So some general principles of exercise in cardiomyopathy. Try to exercise in company if you can. Don't exercise when you're unwell with a significant cold or flu or even a diarrhea or vomiting look. Be sensible about it. Don't go from nothing to triathlons. Not immediately after large meals, especially if you have hypertrophic cardiomyopathy, because that can cause some problems. But you must do some. It's important that you're sensible with reporting symptoms. So things like chest pain, blackouts, near blackouts, or disproportionate or deteriorating breathlessness should be discussed with your cardiomyopathy team. It's important that we discuss alcohol. Now, I don't think saying alcohol is good for your heart is correct. I think we can dispel that immediately. In hypertrophic cardiomyopathy, there's some evidence that obstruction will get worse because of the vasodilatory or opening of blood vessels effect that ethanol or alcohol can have. There isn't a direct relationship between deteriorating the disease process per se in hypertrophic cardiomyopathy, but there may be in dilated cardiomyopathy with some varying evidence recently. Now, we spoke a little bit about mental health, but depression as a label, as a diagnosis, is relatively common in patients with cardiomyopathy. Up to 50% reporting a change in their mood or feeling low in the first year after being diagnosed, and up to 10% being diagnosed and given medication for mood, for anxiety or depression at some point in their career, in their disease path. Thrill-seeking activities, so roller coasters. This is a question we face reasonably commonly, more so from the younger cardiomyopathy population. And attempts to try to answer this are based on surveys on questionnaires of patients with cardiomyopathy. The largest of which we have was about 650 patients with hypertrophic cardiomyopathy. And of those who replied, around 85 to 90% had a go on a high adrenaline ride. There is, of course, a bias involved with those that reply to these questionnaires. But of those patients who went on a ride in this survey, around 1.5%, so 1 to 2%, had a problem on the ride. Often that was a shock from the defibrillator. And a further 1 to 2% had an issue in the immediate hours afterwards, again, often a shock from the defibrillator. So although the numbers are relatively low, and this is important to discuss with your cardiomyopathy team, on balance, it's a matter of how important this is to you and whether you want to accept those risks. In all of this, useful services often provided by the Cardiomyopathy UK can provide you some perspective, a sounding board, a method of communication, a method of being able to ask questions when there's uncertainty. And in all of these lifestyle measures, Cardiomyopathy UK excel in patient education. Pregnancy is often very well tolerated in patients with hypertrophic cardiomyopathy. Sometimes those who have outward tract obstruction will need additional management through their pregnancy and through their delivery. And these sorts of pregnancies should be managed in a combined obstetric and medical clinic. Sometimes patients with dilated cardiomyopathy can have more significant adverse outcomes both for mother and for baby if they go into pregnancy, especially when you consider the medications that patients with dilated cardiomyopathy might be taking before conception. It's important to discuss these things with the team if possible. Okay, I'm going to move on to some pharmacological treatments for hypertrophic cardiomyopathy then. I'm going to start by looking at left ventricular outflow tract obstruction. Now, in LVOT obstruction, we see that blood flowing out of the heart is inefficient. It's not quite obstructed, otherwise you wouldn't be up and talking to us. So it's a bit of a misnomer, but it does describe an inefficient use of energy in the heart. And the phrase hypertrophic in medical parlance simply means thickened or overdeveloped. So in this MRI scan, we see that this ventricular myocardium around here is of normal width. But this ventricular myocardium and septum is thickened, and it narrows the outflow tract from the heart. So a narrow outflow tract means that the heart has to work hard to get blood out, and then there's more inefficient use of its energy. Before we go into pharmacodynamics, I want to talk a little bit about lifestyle adaptation, and this is important. Avoiding dehydration is a large part of managing outflow tract obstruction. And to avoid dehydration, I often encourage my patients to overhydrate, aiming for at least 2.5 litres of fluid a day, specifically non-alcoholic fluid. Maintaining a healthy body weight is important, and aiming for a normal body mass index of between 20 and 25 should be the target. Excess weight makes the problem worse, both because it makes muscles work harder to carry the excess weight, and they therefore need more blood, and the excess weight is living tissue and will take blood away from important organs. In these circumstances, we do advise light to moderate intensity exercise. Now, beta blockers have been an important part of treatment for hypertrophic cardiomyopathy for as long as we've acknowledged the condition. And they're medications that cardiologists are often very comfortable using, but we use them for an array of other conditions also. Anything that acts as a negative inotrope can often be of use in hypertrophic cardiomyopathy. That phrase negative inotrope essentially means reducing how hard the heart works, calming it down. They're common in hypertrophic cardiomyopathy, and they can be effective in treatment of outflow tract obstruction. There's limited data to support the use of beta blockers in non-obstructive hypertrophic cardiomyopathy. Now, at this point, it's probably worth acknowledging that these are a class of medications that are essentially an anti-adrenaline medication. The activity of your heart is controlled by a two-way system. Your brain telling it to calm down, which will slow down your heart rate and reduce how hard it beats. And your hormones, namely your adrenaline, telling the heart to beat faster and to beat harder. And so the beta blockers block the beta receptors in the heart that receive the adrenaline and allow the brain to tell the heart to calm down a little bit. And this works when considering that the underlying pathology, so the abnormality in hypertrophic cardiomyopathy, is essentially that it is overactive and working too hard. Rapamycin and diltiazem are calcium channel blockers and belong to a family called non-dihydropyridine calcium channel blockers, so subtly different from things like amlodipine and nifedipine. They slow the heart rate and also act as a negative inotrope, so can calm down some of the overactive states of the heart muscle. They can be used for patients with obstruction and also for those with angina or chest pain associated with hypertrophic cardiomyopathy. In recent years, there is some evidence for their use in hypertrophic cardiomyopathy genetic variant carriers before they develop hypertrophy. So does it delay progression of disease progress? Disopyramide is often an effective medication for treatment of outflow tract obstruction. Now, it's a relatively old medication and was designed as an anti-angina medication, but used in appropriate patients can work quite nicely. The early fears of there being dangerous side effects and effects with how the heart conducts its electricity haven't largely been borne out, and there are large series showing good safety data now in North America, in Italy, and in our experience in the UK also. They're often used as an add-on medication to beta blockers and verapamil, so don't be too worried if they're added rather than replacing one of those medications. They can often be very effective, and perhaps 50 to 60% of people will find that the symptoms and echocardiographic measurements of obstruction are significantly better when taking these medications. But there is a higher risk of side effects. Now, they're temporary, and when you stop the medication, they go away, but around 10 to 20% will develop side effects that mean that they'd rather be off the medication. That can include dry eyes, dry mouth, blurred vision, sometimes constipation, and for the gentlemen, sometimes prostate symptoms, unfortunately. Now, myosin inhibitors represent a change in the care of cardiomyopathy patients. We've largely been adopting medications that were designed for other cardiac indications, other reasons, other heart conditions that have some efficacy in patients with hypertrophic cardiomyopathy. But the myosin inhibitors, and the first in class of mavacamten, which is often described in some really good trials, was designed specifically for hypertrophic cardiomyopathy patients. Now, when you go down to a cellular and molecular level in the heart muscle cells, you have sheets of muscle, and these sheets of muscle need to move over each other in order to contract. And in hypertrophic cardiomyopathy, the sheets move over each other too much, and the activity state is too high. There's too much contraction going on, and it doesn't really relax properly because the myosin, which is one of the sheets, is attached to the actin, which is the other sheet. Now, mavacamten does a good job at relaxing some of and inhibiting some of this myosin from combining with the actin and causing contraction, so it does calm the heart down. It reduces strain in the heart, reduces the overactive state, and has been effective in trials at treating left ventricular outflow tract obstruction. And there's ongoing study to see whether it's effective in those with non-obstructive hypertrophic cardiomyopathy. When we consider the change in quality of life associated with this medication, and while the seminal trial is called Explorer-HCM, patients who are taking mavacamten had a significant improvement in quality of life scores. Things like how well do you get on doing good dailies of activity living, how is your breathing, do you have any chest pain, all form part of these questionnaires. There was significant improvement compared to those taking placebo in this trial in quality of life score and overall scores. I want to take a moment just to look at this graph because it tells us how much of a difference this medication makes. The higher up on this graph, the better the effect, because that shows you that the improvements in scores on a questionnaire are high. This line here represents no improvement beyond how they were before a trial started. And a lot of these medications lots of these trials here are medications that are used for cardiac conditions, so namely heart failure, Dapagliflozin, Entresto, candesartan. Over here, we have trials that are involved with usually valve studies, so replacing a dysfunctional valve or adapting a dysfunctional valve. For Explorer, we see that it has a significant change in quality of life, way and above those standard heart failure trials, and somewhere akin to having a heart valve procedure. So it's a tablet that's delivering an improvement in quality of life that is beyond what we see in most tablet trials. This is a step change in management. It is translational medicine, going from looking at what goes on in the heart, designing medications to treat that abnormality, and transferring them to the care of patients with cardiomyopathy. And this is likely to reach the UK in some form in 2022. It may be that it's an early access to medicine scheme, and not everywhere, not everybody can get it, but we're likely to get some access at some point next year. Now we think about the treatment efficacy in patients with left ventricular outflow tract obstruction. Again, I want to take a moment just to look at this graph, because this shows us how many patients are left with symptoms and outflow tract obstruction on the medication or on the treatment that they're given after reassessment. So after beta blockers, up to 88% of patients in this study would have some symptoms or some outflow tract obstruction on beta blockers. Here we have disopyramide, so there's a change in that less are left with symptoms and outflow tract obstruction. With mavacamten, it dropped down even further. And when we get towards septal reduction therapies of alcohol, septalation, and myectomy, we see that there's a very low chance of being left with outflow tract obstruction. So with each of these step changes, the chance and effectiveness of the treatment is higher. But the further along here we go, the increasing risk of the intervention. Beta blockers are generally very well tolerated and don't have major risks associated with them. Over here we have myectomy, which is an operation and carries some risk. So it's a trade-off between effectiveness of the medication versus the risk that it poses to. Now there are other medications available in hypertrophic cardiomyopathy, and outflow tract obstruction represents a common but distinct form of HCM treatment. Overall healthcare is aimed at treatment in two principles: living longer and living better, so reducing symptoms. So we have to consider several other clinical scenarios in hypertrophic cardiomyopathy. Outflow tract obstruction is one, but also treatment of atrial fibrillation, of heart failure symptoms, of diastolic dysfunction, and microvascular ischemia is important. So then we think about angina. Now, angina is a symptom. It describes strangling and anxiety at the breast. It describes a chest pain. So it's not a diagnosis per se. And angina, or chest discomfort with effort, is usually not dangerous in patients with well understood and well studied hypertrophic cardiomyopathy. I often use the phrase in my patients that this is just pain. It's not dangerous to the heart pump at the time, nor will it cause deterioration in the long term. And we try to find a way to work through this with medications and still stay active. There are some complex underlying mechanisms to this in hypertrophic cardiomyopathy, but often we see really good responses and symptoms to medications such as ranolazine or verapamil and diltiazem. I've emboldened ranolazine because it actually works principally on one of the mechanisms that is quite abnormal in hypertrophic cardiomyopathy, and almost by coincidence, it works quite nicely for angina. Nitrates are a medication that are not commonly used in outflow tract obstruction because they can actually make this worse and can lead to symptoms of dizziness or lightheadedness or even collapse. So there's something to discuss with the cardiomyopathy team if you're taking a nitrate with a diagnosis of hypertrophic cardiomyopathy. Amiodarone is an anti-arrhythmic medication. So arrhythmias are abnormal heart rhythms, and it's mostly used for atrial fibrillation. There are some circumstances in which amiodarone will be used after a cardiac arrest in conjunction with other medications and often with devices. It's shown to be safe for use in patients with hypertrophic cardiomyopathy in the short to intermediate term. Long-term treatment can be complicated by the side effect profile. Now, the longer somebody's taking amiodarone, the longer the risk of side effects. And so therefore, a medication prescription of many years has to be considered carefully. Anticoagulation or blood thinners are often used to reduce the risk of stroke in patients with cardiomyopathy. Now, atrial fibrillation describes an irregular heart rhythm coming from the top chambers or the atria. Atria, top chambers, fibrillation, irregular rhythm. In approximately a fifth of patients with hypertrophic cardiomyopathy will develop atrial fibrillation at some point towards their 15s. In atrial fibrillation, because the blood flow is irregular, there's a risk of forming clots in the heart, and there's therefore a high risk of stroke. We try to offset this by providing medications that prevent their blood clots forming in the heart. This is what an anticoagulant is. Historically, this was warfarin, and a lot of hypertrophic cardiomyopathy guidance will cite warfarin, but this use for AF has largely been superseded by the newer direct or novel DOAC or NOAC anticoagulations. And some of these are listed as edoxaban, rivaroxaban, apixaban, dapagliflozin. Warfarin is still preferred in those with replacement heart valves, so anyone who's had an operation with a heart valve replacement should really still be on warfarin unless there's a significant risk of that and the need to be on alternative medication. Now, with any blood thinners, there is a slight increased risk of excess bleeding, but this is small, and this is something to discuss with your cardiomyopathy team, and it will be considered before initiating this medication. Okay, so I'm going to talk a little bit about some pharmacologic things with dilated cardiomyopathy. Now, there is some crossover with classes of medications used in hypertrophic cardiomyopathy. Beta blockers, cardiologist's favorite drug. They are also commonly used in dilated cardiomyopathy, and they tend to be used once a diagnosis is established and everything is nice and stable, rather than the first hospital admission when somebody's really unwell. Once things are sorted and stabilized, that's the time to start beta blocker medications, and they're usually long-term medications, and they're very effective at what they do. They are, again, an anticoagulant medication. And listed here are propranolol, atenolol, bisoprolol, nadolol, and nivolol, and carvedilol, and the use of dilated cardiomyopathy or heart failure is also a common medication. ACE inhibitors, and this class of medication have a really long-standing history in dilated cardiomyopathy and in heart failure. It's important that we understand that although some patients with dilated cardiomyopathy can also have heart failure, it's not necessarily the case for everybody with dilated cardiomyopathy. So some of the heart failure medications and heart failure medication guidelines can't be extrapolated to everybody with dilated cardiomyopathy. Some of the nuances might need to be discussed with your cardiomyopathy team. In general, ACE inhibitors support the heart and reduce how hard it has to work. But in some circumstances are being replaced by Entresto, which is a new medication at the moment reserved mostly for people with severe systolic dysfunction, so very weak heart pump, and significant symptoms associated with this. Entresto is a combination of sacubitril and valsartan in one tablet, so it's two medications in one tablet. It's a change in approach in the last few years with this medication because it was shown to be really effective at improving quality of life, reducing heart failure admissions, and even improving length of life, so prognosis for those with left ventricular systolic dysfunction, which is often the case in dilated cardiomyopathy patients. The medication was that good that it's now being studied in those with non-obstructive hypertrophic cardiomyopathy with reduced ejection fraction to see where it can help in this category of patients as well. Dapagliflozin is a medication that has been adapted from the world of diabetes, and it shows a substantial reduction in heart failure death and symptoms in heart failure patients. And again, these studies are heart failure, not specifically dilated cardiomyopathy. We need to be careful about using those terms interchangeably because there are some differences. It changes the way the heart uses its energy, and it is used at the moment as an add-on to regular medications. There's a variable rollout to speed of access to this medication, as it was only first approved by the National Institute for Clinical Excellence in December 2020. Okay, I'm going to move on to tablets and talk about interventions now, and this is predominantly related to obstructive hypertrophic cardiomyopathy. Now, when we consider disease paths in hypertrophic cardiomyopathy, though there is some interchangeable nature to the disease paths that patients follow, generally we see that a lot of patients are actually asymptomatic. In this category of heart failure, we have a low number of patients, but in heart failure is outflow tract obstruction. Within outflow tract obstruction, we have treatments in the form of medications, which we discussed, or invasive therapies. Could return to what outflow tract obstruction is, will show us that the hypertrophy in the basal septum here will narrow the outflow tract. So there is a structural change in the heart that means the blood flow out of the heart is inefficient. If we then consider what the target of septal reduction in hypertrophic cardiomyopathy is, it's quite literally to change the shape of the septum. So in the cartoon here, we have the left ventricle with blood coming in and it's about to be ejected out through the aortic valve this way. And this hypertrophied heart muscle or myocardium. Here we see a crater that's almost been dug out of where the hypertrophied myocardium was. And this is an example of an MRI scan before and after treatment with septal reduction. And we see that the septum here that was hypertrophied has got a crater in it, and the blood flow out of here is now straight and more efficient. In alcohol septal ablation, we acknowledge that every piece of living tissue has a blood supply. And if we can find the blood supply to this piece of living tissue that we need to remove, then we can kill this tissue. And that's what ablation means. The phrase alcohol septal means that we are injecting pure alcohol into one of the septal arteries. This is done by inserting a plastic tube into the coronary artery. This often goes in through the wrist. So this is a catheter, cardiac catheter. Then pass a very fine wire down into the blood vessel supplying the thickened heart muscle. You can then pass a small balloon over this wire, blow this up and obstruct this artery so that you now have a sealed system just to this piece of heart muscle. You can then inject beyond the balloon and alcohol goes into this piece of heart muscle and can kill. Now, the effect of alcohol ablation sometimes is seen immediately, but sometimes takes some months. We see here this obstruction with the hypertrophied myocardium. Now, this is an MRI scan 2 days after an alcohol ablation. And we see this thick black area here. Now, this is the piece of myocardium that has been killed at the alcohol ablation. And this is dead myocardium. This tissue will take some time to retract and go back to where, and to shrink and to open up the outflow tract. But if we look at these pictures again in 6 months' time, we see this white area here is dead or scarred or fibrosed heart muscle. But this is an empty area where that thickened heart muscle was, so it's shrunk back. And this opens up the space of the outflow tract, allowing blood to get out. Next, we must consider myectomy, and this quite literally means muscle removal. So if you can shave some of this thickened heart muscle off, you can open up the narrowed outflow tract. Now, in previous presentations, I've shown some videos of myectomy operations with the heart muscle being removed and received some feedback that it might be a little gruesome. So I'm going to revert to the original demonstration, the original diagrams back from the papers back in 1959, which describe quite literally pressing away the valve so you don't damage it and cutting into this heart muscle and removing it. And this has a really long treatment, a long history in the treatment of patients with outflow tract obstruction. I'm going to use some models to demonstrate what I mean rather than actual heart muscle images or videos here. This is a print of a hypertrophied heart. And in this circumstance, a surgeon can practice on the model and remove pieces of tissue, pieces of plastic to open up a groove, to open up this outflow tract, which they can recreate at the time of an operation. So this was the practice and this was the operation. These are pieces of muscle that have been removed. So in some senses, it's relatively routine practice now to print models of the heart so that the patient can understand what's happening and our surgeon can understand what's happening. We can model so that we can use reconstructed views of CT scans to be able to recreate what the surgeon sees from one incision. So this is from the aorta, or from the bottom, from the left ventricle, where blood would try to get out of. And this gives us a really detailed and thorough understanding. We then have the model and can recreate these views so the surgeon knows exactly what he or she is going to see when they go in to do this operation. This often helps our patients understand exactly what our target is as well. Now, both alcohol ablation and myectomy are effective treatments for outflow tract obstruction, and there are pros and cons to each form of treatment. It's important that you have balanced discussions with your cardiomyopathy team. Some obstruction cannot be treated with alcohol ablation alone. In some circumstances, it's not as simple as just heart muscle being thickened. It can involve heart valve abnormalities, or sometimes some heart artery or coronary artery abnormalities. In these circumstances, an operation can remove heart muscle, but also treat these other abnormalities in the heart. The centers can play to their strengths. When we consider taking a tablet versus another tablet, this is equivalent, but that's not quite the same when it comes to an interventional procedure that involves skill and training, like an operation or like an alcohol elevation. And if centers have real strength in alcohol elevation, they may choose that. If, however, they have their real strength in myectomy, then they may choose to do that operation. Generally, when there are no other complicating factors, alcohol elevation is equivalent to surgical myectomy and often holds a lower risk at the time of procedure and a more speedy recovery. Okay, let's talk a little bit about device therapies, because this comes into the treatment part of cardiomyopathy care. I want to mention briefly that you can use pacemakers to treat outflow tract obstruction. Now, it's not common in the UK, but if somebody already has a pacemaker and we can reprogram it, we can often find that they can get significant benefit by controlling the way the heart contracts with that pacemaker. It's not for everybody and should be discussed with your cardiomyopathy team. In some circumstances, we can use pacemakers as part of a pace and ablate strategy. And the management of atrial fibrillation hypertrophic cardiomyopathy is complex, and you could spend a whole day discussing that on its own, and we'll try and do it in a slide or two. Anticoagulation is usually indicated in almost everybody who has atrial fibrillation in hypertrophic cardiomyopathy. And one source of the breathlessness is that the heart rate can go very fast. So the top chambers of the atrium are irregular, and they're telling the bottom chambers to go too fast. It becomes inefficient. In these circumstances, medication can work a lot of the time, but there are circumstances in which they do not do the job satisfactorily. In this circumstance, we can often progress to a procedure where we ablate an electrical connection between the top and bottom chambers of the heart. So the top and bottom chambers are still physically connected, but the control is no longer reliant upon the irregular and fast heart rhythms coming from the atrium. Once this has happened, though, the heart removes its pacemaker and will often go very, very slow. In that circumstance, you need an electrical or electronic pacemaker as a backup, and that will then control how fast your heart goes. And the programming these days can be quite sensitive and respond to things like how much you're moving, how fast you're breathing, and will increase your heart rate to cope with this. So often this provides an intermediate solution where it won't quite be physiological, but will be close and will improve breathlessness in those patients who've got uncontrolled heart rates in atrial fibrillation. When we discuss devices and defibrillators, we first must understand what an arrhythmia is, because this is a term that cardiology teams use quite loosely. It's a series of abnormal or irregular heartbeats, and it's caused by the electrical pathways that are in control of how your heart works. They synchronize your heartbeat. If they last long enough, they can cause symptoms, and if they are dangerous ventricular arrhythmias, then they can lead to cardiac arrest. Sometimes people will feel unwell before this, with dizzy, faintness, or lightheadedness. And in all forms of cardiomyopathy, it is our duty to consider if a defibrillator or implantable cardioverter defibrillator ICD is appropriate. So what is an ICD? Well, generally this is a pacemaker box, and in most circumstances it has leads that go down to either inside or on the outside, inside the heart or on the outside of the chest wall. And its job is to recognize dangerous abnormal heart rhythms and shock or defibrillate the heart back into its normal rhythm. In general, in your cardiomyopathy clinics, though, if we are considering a defibrillator, there'll be one of two forms usually. One is the traditional transvenous implantable cardioverter defibrillator that has a box underneath the skin, underneath the collarbone, and wires that go into a blood vessel that then goes to the heart. This holds many benefits in patients with cardiomyopathy, including the ability to act as a backup pacemaker, and then the ability to use more medications. In some circumstances, a subcutaneous ICD can be appropriate, and this is entirely on the outside of the rib cage, so underneath the skin, but on the outside of the chest wall. The box is on the outside left lateral aspect of the chest, with leads that are then tunneled up to just over the other side of the heart. So this can deliver a shock between the tip of the lead and the box. Now, the benefits of a subcutaneous ICD are that it isn't inside the heart and it isn't inside the blood vessels. And so in theory, there is a reduced risk of blood vessel complications or infection complications in the long term. The downside is that you can't use it to pace the heart, and therefore it doesn't have any use when you're trying to increase medications, for example. So pros and cons to each, and again, worth discussing with your cardiomyopathy team. Both boxes will show a slight protrusion over the skin, and there will be a slight scar over where they go in, and the procedures are done under local anaesthetic. So how does this work? Well, the ICDs monitor your heart all of the time. They watch every single heartbeat. If they detect a threatening heart rhythm, then it will act in one of two ways. The first is called anti-tachycardia pacing. Now, a transvenous defibrillator will do this, but a subcutaneous defibrillator will not. In this circumstance, the device might sense that the heart is going 170 beats per minute and decide to then pace the heart even faster. So it takes control and paces the heart at 190 beats per minute. Once it's done this for a few seconds, the device is then in control, and it can slowly ramp down how fast the heart goes so that it gets it back down to normal. And in these circumstances, this isn't a shock, and the patient may not be aware of it. Sometimes they may be lightheaded or dizzy, but it passes. If anti-tachycardia pacing doesn't work over a subcutaneous device, defibrillation is an electric shock which resets this abnormal heart rhythm so that your own pacemaker can take over again. The questions that often come with defibrillators: can I set it off myself? Which seems unlikely, especially in young people, when we will program around this so that heart rates above around 200 beats per minute would be the ones that it acts on. And you really struggle to get your heart rate to go up 200 beats per minute, no matter how many roller coasters you went on. But these sorts of things are worth discussing with your cardiomyopathy team. In general, it's safe to get excited, have sex, and have an argument. You should enter arguments aiming to win them. You can again discuss this with your cardiomyopathy team. Your ICD is programmed to recognize circumstances in which your heart rate goes fast appropriately. Cardiac resynchronization therapy. Now, this is largely used for patients with dilated cardiomyopathy and in some circumstances advanced hypertrophic cardiomyopathy. This is an attempt to provide better coordination or resynchronization to a weakened heart pump. So the heart pump has got both reduced strength and then additional dysynchrony. It usually involves 3 leads into the heart: a lead into the atrium, the top chamber, a lead inside the right ventricle, and a lead on the outside of the left ventricle in a vein, so they can then sense and control both the atria and the ventricles. This is sometimes called biventricular pacing because it's both ventricles, and can also include a defibrillator component. When we consider how cardiac resynchronization therapy works, I want us to look primarily at this chamber here. This is the left ventricle. We start with not only a weakened pump, but this wall going at different times to this wall. So it's a much less effective pump. Once this is recognized, the lead that goes and sits on the outside of the left ventricle and on the inside of the right ventricle can deliver an electrical stimulus to the heart to tell it to pace at the same time. Now, you don't feel this, you're not aware of it, but it resynchronizes these walls of the heart and provides us with a more effective heart pump. In some circumstances, heart transplantation can be considered. It's a complex undertaking to be considered when other management has not worked. Most transplant internationally is actually performed for dilated cardiomyopathy. And the phrase used in databases is often non-ischemic cardiomyopathy. But the number of patients with hypertrophic cardiomyopathy under consideration for transplant is increasing. The post-transplant survival in patients with hypertrophic and even dilated cardiomyopathy is good, but there is a significant waitlist mortality. And this is people who are waiting for an appropriate heart for them because it is complex trying to find the correct heart. When we consider what conditions lead to an indication for heart transplantation, I want us to look at the dark blue here, which is non-ischemic, and the green, which is hypertrophic cardiomyopathy. In young adult patients, so between 18 and 40, you see that most, even 2/3, is done for dilated cardiomyopathy. This becomes slightly less as you go to 40 to 50, 60 to 70, and then over 70 years, where heart attack or ischemic cardiomyopathy takes over. Now, hypertrophic cardiomyopathy accounts for a handful here of 1 in 20 young patients, and then even reducing ever so slightly along here. So it is predominantly dilated cardiomyopathy that leads to transplant. But this is a consideration when other treatment is not working for us. And this is done in specialised centres across the UK, a handful of which are available for transplant assessment and then performance of the operation. Now, a short mention of gene therapy, because it is something that is exciting, but also in very primitive stages. It's not something that is close to a prescription pad anytime soon, I don't think. But in short, it's the introduction of normal genes to take the effect of abnormal genes, to replace them or to act on their behalf so that the body can function appropriately. There are several different scientific strategies that have been explored successfully in test tubes and used in animal models and in stem cell models of hypertrophic cardiomyopathy with promising results. So these things are good science, and they're the early stages of translational medicine. They haven't actually been used in clinical patients to this point. You see, when the gene is effective at being replaced in some stem cells, the amount of normal protein replaced is up to 80% of the control level. So this means that 80% of the gene is doing the job and creating the protein that should be seen in the heart. So when we consider the treatments that are available for hypertrophic cardiomyopathy, we can categorize them. I personally put lifestyle at the top because no matter what else happens with the other categories, living healthily makes a big impact on not only your outcome from hypertrophic cardiomyopathy, but your quality of life, your mood, and your mental health. It is important to stay active, to maintain a healthy weight, and to minimize alcohol intake. Medications can be categorized into thinking about treatment for outflow tract obstruction, specific treatment for angina, a whole new category of perhaps disease modification with the myosin inhibitors, which are exciting times in hypertrophic cardiomyopathy. And then specific treatment for atrial fibrillation that can include blood thinners or anticoagulation, and other medications to try to control the rhythm, such as amiodarone, or perhaps slow down the heart rate, such as beta blockers. We then can engage with the use of devices, being pacemakers or defibrillators. Pacemakers, sometimes the heart's going too slow or to use an atrial fibrillation. Defibrillators when we perceive the risk of sudden cardiac death to be too high. Septal reduction therapy is available for those with symptomatic outflow tract obstruction despite the optimization of medications. In the UK, that largely comes down to alcoholization and surgical method. In some circumstances, we need to consider advanced heart failure care with additional categories of medication, and in some circumstances, transplantation. When we consider the dilated cardiomyopathy, you can see there's some similar themes. Lifestyle is also very important. Maintaining activity, maintaining a healthy weight, and minimizing alcohol are all important. The medications have a slightly different direction, and they're aimed at managing the left ventricular systolic dysfunction, so the weakened heart pump. Atrial fibrillation is also an issue in dilated cardiomyopathy, so we have the same categories of medications of anticoagulants and antiarrhythmics. In these circumstances, we have to consider fluid accumulation, treatments of which is usually with diuretics. Devices probably play as prominent a role in the care of dilated cardiomyopathy, and this is where we often rely on resynchronization of biventricular pacemaker devices, usually with a defibrillator component. And we can consider advanced heart failure care with new or additional medications that have reached our UK market in the last couple of years, such as Entresto or Tract. And in these circumstances, transplantation assessment may be appropriate if we have significant ongoing symptoms of hospital admissions despite treatment in all of the other domains. Thank you for your time. I think I've banged the drum on lifestyle quite loud enough there, but it is important, and it's the sort of arena that you can take control of, and that's really important when you're managing long-term cardiomyopathy, for you to have some control over your own condition. Thank you.